Okay, that's fine. Thank you. Is it okay if I give you a microphone? So you can sort of step away from the left bit and sort of fire on the microphone. You're talking on the left hand, like you said, with microphone. Yeah, you okay with that? Yes.
Right. Do you have the mic? Well, I'm just going to stand there and speak. Yeah, yeah.
I will introduce you first. So
Okay.
you'll be on in a second.
All right, thanks.
Ladies and gentlemen, we'll proceed with the second session right now. Second session is entitled Research and Innovation to Transform Lives. I'm going to have 4 speakers in this session, so the procedure is as in the first session, presentation and short time to have questions and answers. I'll introduce my speakers one by one. This time might be a little bit more clear. So first we have Mrs. Powell from WHO, based in Geneva, working in medicine safety program, is a medicine safety program manager for the International Drug Monitoring. Working in the technical unit for quality and safety assurance, which is directing and coordinating authority for health within the United Nations system. Please.
So good morning. It's a great opportunity to be here. I'm Shanti Pal. I've been working with WHO the last 13 years, and 13 years running actually. But the program that I'm just going to talk about very briefly has been there for several decades, over 40 years. And so it was wonderful that we got the opportunity to further the goals of our program through the European Commission's supported monitoring medicines project under the Framework Program 7. So just very quickly, the WHO Global Program for Safety Monitoring of Medicinal Products is started with the first thalidomide baby being born in the 60s. And that horror, that horrible event, galvanized several countries to come to the World Health Assembly and endorse a resolution for the creation of a system that would pick up information related to safety of medicines in a post-marketing context, put it together, investigate and share the knowledge for the prevention of similar occurrences. That's how the WHO program started over 40 years ago. And the definition of pharmacovigilance, the means for medicine safety, it is the science and activities relating to the detection, assessment, understanding and prevention of adverse effects or any other drug-related problems. So this is how, this is the full definition of this area. And traditionally, it has been practiced as a method for picking up information related to medicines and the harms they cause. But more and more, and that is why I highlighted the phrase, any other drug-related problems in red. More and more countries, particularly in resource-limited settings, are also using this to pick up use-related and product-related and quality-related problems. And so by investing, therefore, in countries, and this is the kind of argument now we take to countries for investing in pharmacovigilance, that not only do we pick up adverse drug reactions with pharmacovigilance, but we can also pick up SSFFC, which is substandard, spurious, falsified, falsely labeled counterfeit medicines, for example. You would be able to track inappropriate use of medicines, irrational use of medicines, and you would be able to track the occurrence of system failures leading to medication errors. So pharmacovigilance is a given in most advanced settings. It is practiced as a discipline that can ensure the best use and the safest use of medicines in population. But surprisingly enough, you will see that this has taken quite a few years to root in low and middle-income countries. But perhaps I shouldn't say surprisingly enough, because these countries are also battling with a multitude of problems, and so it's a question of priority setting. So the priority has been primarily to address problems of HIV, TB, malaria, and getting access to those medicines. But in order to in order to make a case, we have for pharmacovigilance, we have WHO as well as many other countries have and many other organizations have carried out surveys and assessments of pharmacovigilance practices in low and middle-income countries. And the message is consistent. The findings are always the same, that pharmacovigilance fails in these settings due to lack of political support, lack of resources, human and substantive, lack of competence. Even when you do have a certain infrastructure, there is not enough capacity. And when you do have capacity and some of the systems, still they're not delivering for various reasons. And even when they do deliver, this information that is captured by these systems is not being shared across the low and middle-income countries. So these are the messages that we pick up continuously. And if you look at the pie chart to the left of the screen, what I'm trying to demonstrate here is that, so over years, countries do have some systems for picking up post-marketing safety issues with medicines. But if you see, the So we have a database in Uppsala Monitoring Center in Sweden, where all the data are compiled of individual case safety with medicines. We have some 8 million reports in this database, but the majority of these reports are coming from North America and from Europe. The rest of the countries are contributing to very little, as you can see by the small sections in this pie chart. And so that is a challenge. So we need to first build systems, make them functional, and make sure that what we learn from one part of the world is shared across the globe. So, and if we wouldn't do this, why would that be a problem? Because if you look at the drugs under development in the pipeline, and if we would focus on the 3 big diseases, HIV, TB, and malaria, and if we would focus on medicines for neglected diseases, we could say that more than 300 medicines are in the pipeline. But, and at least half of them would be used in low and middle income countries in the coming years. And so here we are, with all good intentions, to bring in medicines which are not yet very well characterized because they would be relatively new, bringing those medicines into settings which have very little capacity to really monitor the use of these medicines and monitor the safety of these medicines. So that is the problem. For instance, I thought the more immediate example is bedaquiline. Bedaquiline has just been approved as, by the US FDA as a medicine for MDR-TB. And this is going to be very soon, I think in just a few months, will be made available in some parts of Western Africa. So, and these are countries, Cote d'Ivoire, Burkina Faso, Burundi, Rwanda, and so on, which do not yet have pharmacovigilance capability. And we do know that bedaquiline has serious concerns. Of course, it's a benefit of assessment because it is the benefit of having a medicine in a population which is very seriously challenged by the disease. Therefore, we have to look at the serious events with the medicine in that context. But even so, you do need systems that will look at a medicine that we do not yet know fully. And so just to give an example. So with all these reasons, for all these reasons, WHO, the last 7 years, has been working with countries to create systems. And the focus of creating these systems has been in low and middle income countries, particularly in Africa. So to the left, you see what it was like about, say, in the 90s. And today, this is what it looks like to the right of the screen. So the colors, the blues and the light blues in a shade, are those countries that have pharmacovigilance systems now in place. The light blues are those that have some kind of a rudimentary system but are not yet functional. So this has been one of the drivers for the strategy for WHO in pharmacovigilance, to build systems first. And having built those systems, then we have to make sure those systems will have the capacity to deliver. So the first starting innovation for WHO has been not to go this path alone. So we have turned to partners, and the most traditional partner for the program has been the Uppsala Monitoring Center, more than 40 years. But more recently, starting in 2009, we've had partners in Accra, Ghana, in Morocco, Norway, Netherlands, and very recently, just a month ago, in Netherlands. So with these collaborating centers, we are developing solutions, and we are developing capacity to make those pharmacovigilance systems that we've been building to deliver. And how do these collaborating centers deliver? A lot of it has been through capacity building, and a lot of it has been through building innovative research solutions for data exchange, data management, and so on. And also, to being closer to the ground where the support is needed by creating a network of partners in Africa, of Africans, for Africa. So this is a network of consultants in Africa who have the expertise, who can be available for the pharmacovigilance questions in the country. So these have been some of the innovative approaches that WHO has been adopting. But there are many more questions that remain unanswered. There are many more problems and challenges on our wish list. And so the wish list is very, very long, and will continue to be long as we face with many of the disease and high burden diseases in resource limited settings. But, and this, when we were struggling with this wish list is when the FP7 call came, and we responded to that call with some of our challenges as a proposal. And here is our consortium of 11 partners spread through Europe, Africa, the Western Pacific, and of course WHO. So 11 partners, we could come together with our common problems and convert some of our wish list items into work lists, supported by this grant from the ECFP7. So we had 14 work packages within this project, and we are very pleased with the achievements through these work packages. Just to name a few, to the left of your screen, you will see that we've been able to develop several methodologies, because what works in advanced settings might not work in low and middle income countries. That is a lesson we've learned. And what works in any medicine monitoring might not work in a medicine being supplied through a public health approach. These are lessons that we've learned. So we have learned to develop methods that are appropriate for the questions in hand, for the settings in hand, and those guidance documents to the left are capture those methods that are suitable for monitoring medicines in public health programs such as HIV, TB, and malaria, and immunization programs. And we've also set up a resource repository, that is, so that resource-limited settings do not have to shop around for the best evidence and best knowledge and best advice in pharmacovigilance, but they can go to one information portal and pick up all the information that would be relevant for practicing pharmacovigilance in their setting. And then we've also developed a three-tiered approach for monitoring medicines in these settings. We are saying that if it is a known medicine, but and if you want to monitor the safety of these medicines as a part of best practice, as a part of everyday health care, then adopt a spontaneous reporting methodology, which is the pink circle. On the other hand, if through this monitoring you have a problem that you want to characterize and quantify, then go for a targeted spontaneous reporting of that problem. On the other hand, if it is a medicine like bedaquiline, which has just been introduced into the system that you don't know very much about, and you want to monitor patients quickly in a short period of time, then you go for a cohort event monitoring, where you would have a cohort of patients that you would monitor intensively to capture anything and everything about use as well as about harms and benefits, additional benefits with these medicines. So now I'll just quickly go through this. Now, one of the challenges that we have understood better is that you create systems, countries start collecting data, but that data isn't being shared. And then we have investigated why is that the case? And we've learned that because the data are being collected in a way that doesn't support comparison. The formats are different, the data elements are different. I mean, this in ICH World, which is the International Conference for Harmonization, ICH World of Europe, the United States, and Japan, there are standards that are comparable across the three. But in the rest of the world, there is a struggle to have those standards. And also, so we have understood that the starting point would be, beyond creating systems, make sure that what comes out of those systems is comparable and is of a standard that is compatible with the international standard. That's something we've learned. So one of the tools that the program, the WHO program, together with its collaborating center in Uppsala, has developed is Vigiflow, which is a data management tool, which ensures that data are collected in a compatible fashion and also can be exchanged in a seamless fashion between countries, between regions, and across the world. And so this is WHO's solution for implementing the ICH standards in non-ICH countries. And this Vigiflow, the data management tool, is both a reporting tool as well as a national database. So it's not just that you're collecting data in rudimentary systems like XML files, but you will actually have management software that serves as a database for your local requirements. And it can also support diverse marketing authorization for your operations within the country, because quite often marketing authorization holders from advanced settings are operating in the lower middle settings and have obligations to share data with their country of origin. So for all sorts of questions, this data management tool seems to hit the nail. So just to give you, and also this data management tool has a search and statistics module built in it. So you have an opportunity to collect, you can share it, and you can investigate it. You can interrogate the data using the search statistics built into it. And so the countries that I have now colored in blue on this are the countries that are currently using this data management tool. So the WHO has made it available to them. So there are some 50 countries currently using this tool. And just to capture graphically how it works, so you can have multiple centers within a country, and then you can create portals for these various centers, all of which would have an access to the data management tool, with the ultimate data being coming to, for instance, the National Regulatory Authority, where is usually the pharmacovigilance center located, and then industry can also be invited to partake in this process. So, what has been the impact of making such a tool available? So today, I could say, if I would focus on Africa, I could say that many countries in Africa are now able to contribute to global learning. Not only do they have their own national database, but they're also contributing to the WHO global database, which is based in Sweden. And therefore, they are part of a global learning process, these countries. And the data, of course, are routinely being investigated through a data mining process in Sweden. And the immediate success story has been that we have a signal of adverse reaction coming out of data exclusively based on African information. And it makes sense because this is for medicine that is used to the biggest extent in Africa, an anti-malarial product. Amodiaquine artesunate, and the signal of extrapyramidal symptoms was investigated, was determined from data from Africa. It was communicated to the company, and the marketing authorization holder has now updated the product information to reflect this learning. So that is an impact of innovation, and we hope we will have many more to share in the coming years. And then we're also saying that the best way we can convince policymakers to invest in pharmacovigilance is to show that what we collect can be used in so many different ways. So there is this multiplicity and the scale of economy that is possible with pharmacovigilance data, not only for understanding about adverse drug reaction side effects, but also how the medicines are being used, and possibly what kind of quality issues are there which may result in product failure, for example, in the country, and also programmatic errors in big immunization campaigns. Pharmacovigilance can also capture programmatic errors, for example. So these are some of the additional information that are possible. So here I have mentioned about the SSFFC, which was, so we were able to demonstrate that it is possible to develop a tool to query the data systematically in the global database. So an algorithm to identify problems due to poor quality products, which are flagged as pharmacovigilance events, that is, as safety events, and then use that algorithm to understand the movement of poor quality products across the world. It is possible to do it. We have such an algorithm. The next step would be, of course, so these are some of the terms that we would be critically looking for in a reporting pattern when trying to pick up an event due to a poor quality product, such as therapeutic ineffectiveness is a reportable term, product quality issue is a reported phrase, and so on. So having developed such an algorithm for detecting clusters of poor quality in our global database, we would now like to share that algorithm with countries to look for problems within their national databases. So that would be a validation of the use of the tool in a local setting. So this is the step we would like to go, and this is the step we hope another fund such as another project such as the current one will be funded to take it to the next level. And this is another thing that is possible, that if we look at our database, and this is a bit old when we actually wrote this proposal, but it is about 2% of all the reports in our database, in the global database, flagged something called medication errors. So what we did then as a next step, through this project, we developed a guidance document for investigating, for the analysis, the root cause analysis of those medication errors. Why did they occur? What could have been done? And what should be done? And there's a proposal on preventing the recurrence of the medication errors. So that is another product that has come out of this project. And pharmacovigilance worldwide has developed primarily as a professional healthcare, as a activity of healthcare professionals. But we have made the case that if you do not listen to patients, you do not have the full picture, because patients are those who are actually enduring some of the negative impact of those medicines. So they would know better and would be more interested in sharing that information than maybe a healthcare professional who is not quite grasping the severity of the situation. So if we say that if you don't count on patients, patient care will not count. So we have learned that not only do we identify new signals, new information, by listening to patients about medicines, but we can also get that information much quicker. So a survey for various practices across the world was carried out through this project. And we've now also, with the help of this project, been able to develop guidance on how to set up patient reporting systems in countries, so that patients will have an access to a simplified tool that will allow them to report key elements that are important when they are trying to report an adverse event with a medicine. So we have developed such a tool, and we have developed the guidance document for pharmacovigilance centers in the world in preparing to receive reports from patients. And these are currently being piloted in some countries. So these were some of the innovations that were possible, and through the ECFP7 project, that is, to build systems, to strengthen systems, to support the additional use of data on medicine safety, and to bring in additional partners to our learning process, that is, patients. And we hope that in the coming years, through other projects, and I hope that through our collaborations with some of you in the room, we will be able to scale up and provide a proof of concept for some of the pilot efforts possible for this project. Thank you.